Okay. So if you were going to offer clinicians one or two or three main take-home messages for their clinical practice based on the findings you report in your paper here, what recommendations would you make to clinicians?
I would say the first lesson to be learned from our line of research is that clinicians themselves are lousy at identifying patients who are going to end up deteriorated. And so they cannot rely on their clinical intuition because it's way over optimistic to the.
Okay.
So that if they continue to practice with their intuition for the problem of identifying failing cases, they're going to miss almost all of the patients who deteriorate. So they cannot continue to practice that way if they want to solve the problem of a failing case.
Okay.
That's the major thing.
So the major thing is that clinicians cannot continue to, or they cannot assume that their intuition is going to allow them to anticipate and identify which cases are failing, because if they do that, they're going to be making a mistake.
That's right. So, for example, when we ask our clinicians at our university clinic to, after each session of seeing a client, immediately after the session to identify if this is going to be one of the 10% that worsens, out of 550 clients that they made ratings on, they only predicted 3 would worsen, whereas 40 did. And they were only correct once out of 40. And the one clinician who identified the one case that deteriorated was a trainee. So the licensed professionals with an average of 10 years experience did not identify a single case out of the 40 that eventually deteriorated. So we're not talking, we didn't have to do statistics to find a significant effect. There's essentially zero ability. It's not just a little off, it's like way off.
Way off.
And we think this is because clinicians have to remain optimistic, and so they never make the prediction. They never think anybody that they see will be among the 10% that get worse. Maybe their colleagues will have worsening cases, but they won't. That's what it looks like.
That is fascinating. Okay. And so then if intuition doesn't do the job, I assume there is another take-home message having to do with using tools and measures to monitor outcomes to try to identify those likely failing cases. But I don't want to get ahead of you. But would that be your next take-home message, Dr. Lambert?
Oh, that would be the next take-home message. We developed a brief 45-item measure of depression, anxiety, interpersonal problems, and social role problems like problems at work or problems as a homemaker or problems as a student studying. So whatever your job is, we tried to measure that as well. And so we would call that psychological functioning or mental health functioning. So you can get that down to about 45 items, which means the patient can complete it in 5 minutes. So we developed a measure of mental health functioning that can be taken before every session using about 5 minutes of patient time. And so you can measure it. And of course, we took our measure called the OQ45 and validated it against other measures like the Beck Depression Inventory and the Beck Anxiety Inventory and the Symptom Checklist 90 and other measures of psychological disturbance. So we know it's a valid measure. So it can be done taking very little clinician time We can have the patient come in 5 minutes early, and we can get the information in the hands of the therapist in about 20 seconds after the patient finishes the measure. So we can use a scale to measure it. We develop very sophisticated and quite accurate predictions of treatment failure so that we can identify 100% or close to it, maybe at the worst, maybe 85% of the cases who are going to deteriorate before they do so. So whereas clinicians can't do it with any accuracy, we can do it very well with a psychological measure. So those algorithms that predict treatment failure are the most important aspect of feedback. Feedback amounts to an alarm signal that comes up on a report on the clinician's screen with a red colored marker that says alarm. And so we're not giving people test scores. Well, we give them test scores, but that's not the critical thing. The critical thing takes half a second to look at. It's going well, or it's a predicted treatment failure. And that's the information that we think makes a difference. That's the essence of feedback. This is a at-risk case.
So here Dr. Lambert has described his measure, the OQ45, and the tool he's built that provides the clinician with not just a plot of the patient's score, but a feedback signal that identifies the patient as on track to recover, or what's particularly important to identify, at risk of deterioration. And the tool has been shown effective at accomplishing these tasks in many studies. So we provide a link to Lambert's tool in the PowerPoint slides at the end of this clip. We also provide links to other measures clinicians can use to monitor their patients' progress in treatment. The ones I use myself are most often are the Depression Anxiety Stress Scales, the PHQ-9, and the GAD-7. These measures are in the public domain, so that means they are not copyright protected, and they're available free on the internet in many languages. And we'll offer you links to those measures as well. I also want to mention Psych Surveys, which is an inexpensive online tool that I use. I'm not an owner, or I'm not getting any benefit from mentioning it to you here, but I just want you to have options for an online tool for tracking your patient's progress. So Psych Surveys is an inexpensive one, and it has a large library of measures that includes the DAS, the PHQ-9, the GAD-7, and many others. Very useful for tracking patient progress in treatment. I will say, however, that the Psych Surveys and these measures alone do not provide a clear signal indicating risk of deterioration in the way that Lambert's tool does.